So, good morning, everybody. My name is Brian Schwartz. I'm the Associate Dean of Libraries at Rocky Vista University and a professor in the Medical Humanities Department. I have been at Rocky Vista since we opened in 2008. So, I'm on year 17 in the process of working there. And I was working with Karen and Joanne on some stuff, and they asked if I would be interested in giving a talk to this group on how to teach health literacy in medical education. So, teaching health literacy as a concept and both theory and practice to medical students. And short of hanging out with my kids, playing golf, and occasionally having good bourbon, there's very little I enjoy doing more than talking about social constructivism and health literacy. So here I am. We will save some time at the end for questions. So please save them up, throw them in the chat, and I'll ask my colleagues, Karen and Joanne, to jump in if anything needs to get addressed immediately. So let's go ahead and get started. As we all sort of know, the fundamental pedagogy of medical education, at least for our purposes today, we're going to operationalize it as equipping learners with the knowledge, skills, and attitudes to practice medicine effectively. And so it's the idea of knowledge and skills and attitudes that I really want to sort of be the operationalization of what we're going to talk about for the rest of today. So that applies to health literacy in the idea that you have to talk about knowledge of the concepts, skill in both identifying health literacy deficits and ameliorating them, and coming at everything with an attitude of compassion and of partnership between the physician and the patient. So we talk about knowledge of the concepts. Let's take a second and define our terms. I don't need to read these things aloud to you. We're going to revisit both of them consistently throughout this session, so I'll let you read those. All right, so what is it? The fundamental question of what is it? Let's talk about sort of, before we get into health literacy, let's talk about the idea of general illiteracy in America. And these are stats from a few years ago, which I'm sure haven't stayed static. So 21% of adults in the United States are functionally illiterate, meaning they read at below a fifth grade level, means they can't on a map find an intersection, just as an example of that. 25% are marginally illiterate, meaning they read between a fifth and an eighth grade level, meaning they have difficulties using a bus schedule. So literate, as defined by the US Department of Education, means reading at an eighth grade level. So if you use that as the sort of basic definition, then understanding that, what's that, 46%, almost 50% of the American adult population is by definition of the USDE illiterate. And that means, from a medical perspective, roughly 90 million patients per year, patient visits per year. Health literacy can be broken down. So, moving from general illiteracy to health literacy can be broken down into four general categories. The first is proficient. And those are just a couple examples of things that people with proficient health literacy can do. Intermediate, basic, and below basic. And you can sort of see how this all tracks in the process of these four categories. And I'm generalizing here. And I recognize that there are going to be obviously specific exceptions. But when we're sort of trying to understand the fundamental concept and teach to medical students the fundamental concept of health literacy, of understanding where to meet your patients, how to communicate with and use the idea of the doctor-patient relationship is a way to forge communication processes. It's helpful to understand these sort of four literacy levels. It's a blunt instrument to be sure, but there's still some value in it. So the next thing that you want to explain to medical students and to understand for all of us is why it matters. And let me take a step back at this point. And I'm talking about health literacy as a concept, and I'm talking about health literacy as a teaching modality for medical students. And those two sort of blur. Um, I'll take a step back and talk about ways to communicate this to medical students. And sometimes I'll take a step back and talk about how physicians can communicate this stuff to and with patients. Those aren't necessarily dichotomous. There's a certain synergy, a nuanced synergy between the two. And so if you have specific questions regarding the communication modalities, let me know, and I can address those in a more specific. So, when you're talking about health literacy as a concept and you're addressing it to medical students who spend their life studying anatomy and physiology and pharmacology and all of those sorts of fundamental precepts of being a physician, it helps to situate this in the notion of why it matters, why this conversation is important, and why it's vital to patient care. So, the easiest way to talk about why it matters is talking about how it affects patients and talking about the financial aspects of it, because those sort of bottom line this in ways that are helpful for identifying the relative importance of it. So, patients with limited health literacy are twice as likely to be admitted on visits, 5 times more likely to take medication incorrectly, 7 times more likely to miss appointments, to engage in far more risky behaviors. And I mean that risky in terms of drugs and alcohol and social behaviors and sexual behaviors and all sorts of other kinds of risky behaviors that often land patients in emergency rooms and clinics and doctors' offices with health concerns. 3 times more likely to use the ER as a primary care facility. And so the studies have shown, and the sort of background information about this is patients are more likely to use ERs as primary care facilities when they don't have a primary care physician or aren't comfortable with the medical system or don't have a knowledge of insurance and how to navigate medical systems, because when you and this relates to the twice as likely to be admitted on visits, because if you use the ER as a primary care facility, if you use the emergency room as your primary care doc, then you tend to wait until the issue is more serious. And whereas if you go to a PCP with it, it could be taken care of with a medication or a conversation or some other sort of easy remedy or therapy. It tends to be more serious, and so there are more admissions on this. And the second piece, as we're talking about effects on preventive healthcare, patients' issues related to limited health literacy, this is still the patient response to it. If a patient is asthmatic, they're less likely to know how to use their inhaler correctly or signs of an attack. Diabetic, less understanding of symptoms and insulin levels. A new parent, accurate reading of thermometers, age weight requirements for over the counter medications, all of which can relate to and result in more significant healthcare visits. And let's just talk for a second. I mean, money is always a little gross to talk about in terms of this, but it's interesting for the concept of situating it in how it matters and how it affects the medical system. So Medicare, Medicaid costs, and this is in 2004, so recognize that this is 2 decades old. All enrollees is roughly a little under $3,000 per enrollee. Enrollees with limited health literacy, which means basic or below basic on the 4 caliber chart that I showed earlier, are almost 4 times as much. three and change times more Medicaid costs engaged in the care of patients with limited health literacy. So moving along, you can see and you can explain to your patient or to your students, and they to their patients, and you maybe to docs in a hospital setting in which you're working with them or teaching seminar sessions on this kind of a topic. You can explain to them that this matters from those two fundamental places: patient care and the bottom line sort of fiscal ramifications of the process. So all of that is fine and good. It matters, and we have everybody in that sort of fundamental level of understanding now. So let's talk about how you can tell and how you can fix it. There are a couple of red flags to look for. There are a couple of assessments you can give, and there's an idea of context. So from red flag standpoint, if you give a patient something to read and their eyes wander over the page, it's a red flag. It's not a guarantee. None of these are guarantees, but they're all things that should make you take a step back and think a little bit and invest a little time and energy into the idea that this patient may be coming at you from a limited health literacy standpoint. Eyes wandering over the page, when you read something, if it's in English or Spanish or a language along those lines, you read it from left to right and top to bottom. So if it's in one of those languages and you see a patient's eyes sort of darting around, that may be an indicator. A lack of interest in written materials, hand them something and they just set it down. Frustration or impatience with forms and handouts. This is obviously not a guarantee, since everybody gets frustrated and impatient with forms and handouts that they get, particularly in doctors' offices when they're not feeling well to begin with. Incorrect or incomplete forms. And oftentimes, if you're having a medication conversation, a patient and a physician, and the patient looks at the pills rather than the label, and instead of saying the name of the drug or the reason they take the medication, says the little pink ones or the round yellow ones or something like that, that's often also an indication. Again, not a guarantee, but a potential indication. There are assessments that you can give that are fairly easy to get a hold of for physicians. Those have varying values depending on who you ask and what study you read. And you can ask informal questions in the get to know you phase of what do you like to read? How often do you read? And things like these directions are pretty confusing, and how can I help you? And a big part of this, and we're going to talk about this a little bit more in a couple of minutes, is the idea of projecting the idea of helpfulness without projecting the idea of condescension, of being paternalistic or patronizing. And that's a huge barrier to relationship building and conversations. So it's something to keep in mind consistently when you're teaching to medical students how they can best relate to their patients. So highly literate patients often face challenges also, and a lot of those are based in the context. Highly literate patients often face challenges when it comes to terminology. Functions of the body are hard to talk about for a lot of people. They're sometimes unpleasant to talk about. They've often been shamed for talking about them, and it presents a challenge even for highly literate patients using sort of general literacy as the standard. Interpreting numbers is incredibly difficult for a lot of people. Diagnosis of a major issue and complicated or multiple conditions. I've heard it said by physicians when they're talking about diagnosis of a major issue or complicated multiple conditions or complex self-care processes. If you have to tell a patient that they have cancer and then tell them next week's winning lottery numbers, there's a huge possibility they still will not win the lottery, because very little sinks in to people's minds oftentimes after a major diagnosis or a complicated multiple condition or self-care process diagnosis. And so those sort of contextual things can also get in the way of health literacy, even for people who have general high general literacy. So what can you do? One idea is that you can use a universal approach in the same way that you use universal precautions. If almost 50% of patients have health literacy, then you can operate from the idea that patients have limited health literacy unless proven otherwise. And again, that's something that you do without being patronizing, without being condescending, but you can start from there and work through until it's proven that you don't need to. Communication skills in general, hopefully physicians all know this and learn this, but I think we've all been in enough medical visits that we know they don't always. Speak slowly, avoid medical jargon when you can, use pictures when you can. And this relates not just the physician, not just to a PA or an NP or somebody who is giving the direct patient intervention or patient care, but it's the entire healthcare team. Patient care starts the minute the patient enters the clinic with front office staff and office managers, non-medical staff and medical staff alike. And the universal approach to helping patients ameliorate their own health literacy deficits begins when patients walk through the door, or even before that, when they make the appointment. The idea of Ask Me 3, and these are things that come from the Partnership for Clear Health Communication, and it's this process that physicians, particularly primary care physicians, ingrain in their practice. And I've seen it done, and it can work really well if it becomes a consistent part of the way that physicians relate to and deal with patients. And that is, you ingrain in your patients a culture in which you have them ask the physician at the end of a visit 3 questions. Patient asks the doc, what's my main problem? What do I need to do? And why is it important that I do this? Those are easy ways to begin the communication or to unlock a lot of the communication nervousness or difficulties or shyness that patients often feel with physicians when they feel like they don't have the right words, they don't have the right questions, and they don't have the time or the space, and the physician doesn't really want them to ask questions. So if you create a culture, build a community around the idea that patients always ask these questions, it can be particularly helpful for sort of greasing the wheels for that kind of thing. And the last one that I want to talk about is the teach back method, in which your patient explains the regimen back to you. And the easiest way to do this is to take responsibility on yourself and say something like, this is really complicated stuff. I'm not sure that I did a great job of explaining it to you. Tell me what you're going to do next so I know we're on the same page, or I know that I did a good enough job, or I know that I didn't totally screw this up. It's one of those ways that sort of takes the responsibility on the physician's shoulders or the healthcare provider's shoulders to say to the patient, I want to make sure that I did a good enough job. So will you tell me what you're going to do next so I know that I've communicated effectively enough? And listening to listen well is as powerful a means of communication as to talk well. I actually think that it's more important. I think listening is the fundamental currency of communication, even more than speaking. Um, I have a background in improv, and you learn in improv that the single most fundamentally important thing you can do is actively listen to the people that you're performing with. And so that's sort of ingrained in my nature as to how I communicate. And finally, you want to make sure and create an attitude of compassion. So I want to talk about social constructivism for a second. These are the sort of ideas of social constructivism: communication, dialogue, empathy, partnership, respect, and autonomy. Well, I gave the definition for social constructivism earlier in this talk, but just to revisit it, social constructivism is the idea that all human understanding, knowledge, and wisdom comes from dialogue, from interplay between and among people, and from the idea of communicating about shared lived experiences. That's the only way that we know anything. And the best example that I can think about with this is the idea of where slang comes from. All of slang is socially constructed. It's all built and developed in conversation and interplay and interactions between and among people. And how does this play into the physician patient relationship? Well, we all sort of know that this is the long running joke, right? Please don't confuse your Google search with my medical degree. And the physician brings to the table, and it's important to understand and respect and and situate what the physician brings to the table, and that is the learned expertise of medicine and the human body and pharmacology and therapy and prognostics, diagnostics, and all of those things that physicians learn in medical school, residency, fellowships, and years of practice as they move along the path from being competent to being experts and masters in the medical arts. Physicians bring the learned expertise. But every time a physician wants to say or is tempted to say, please don't let your WebMD search or your Google search be confused with my medical degree, there's a flip side to that that is vitally and fundamentally important for physicians to understand and reckon with and acknowledge, and more importantly, to respect. And that's this: please don't confuse your 1 hour lecture in medical school with my 30 years of lived experience with this condition. And that's when constructivism leads to collaboration. Those two ideas, the physician's learned expertise of the concepts, the patient's lived experience with the disease or with the condition. When those two things come together, it takes collaboration into a new realm where it can become, under the ideal circumstances, shared decision making. And this is really where social constructivism lives in the medical visit. It lives in the idea that a patient having asthma or diabetes or whatever condition it is that they come in with is different than every other patient who has the same condition. When I'm when the physician is sitting in the room with Mrs. Smith, and Mrs. Smith's condition is that she has type 2 diabetes, it's not about the physician's understanding of type 2 diabetes. It's about the physician's understanding of the importance of Mrs. Jones's type 2 diabetes. I may have just mixed up that last name, but you know what I'm saying. It's about that patient in that moment, in that specific point in time. And for that reason, it's very important for physicians, especially medical students, to understand that when a patient and a physician are sitting together in a clinic room, in a hospital room, in a doctor's office, the physician is not the most important person in the room, because it's not about the clinical study of diabetes. It's not about the academic learning of asthma. It's about how that condition affects the life of the patient sitting in front of them at that moment. And one of the ways that I like to teach health literacy to medical students is to put this slide up on the screen at the beginning, because medical students have a difficult time putting themselves in the shoes of building up empathy and compassion for patients who have limited health literacy, because they have rarely been been in a situation in their lives when they don't know, when they don't understand, when they're not the most important person or the most educated or smartest or most knowledgeable person in the room. And so you put this up, and they will almost invariably figure out what this says. But it also invariably takes them a minute. It puts them in a position where reading is not second nature. It's not reflexive. It has to be intentional. It has to be thought about. It has to be worked out. And that changes the game. And then you show them what it is that they wanted to see. And having that moment of empathy, having that moment of connection, of establishing compassion and partnership and understanding between the physician and the patient, between the clinician and the person knowledgeable in the disease state and the person knowledgeable in their instance of the disease state, is where you socially construct a new understanding. And it's not just about my lived experience or my learned expertise. It's about how those two things can play together in concert in order to make this patient, this time, in this situation, better, healthier, more comfortable, and more able to go on and live the kind of life that they want to live. And situating it that way for medical students, situating it that way for physicians, and situating it that way for patients allows everybody to sort of understand the fundamental truth behind the idea that communication is king and is key to all of